Thanks so much, everyone, for joining. Today's the second lecture in our acute care series with Dr. Desai. We're going to be discussing the management of obstructive shock in PEs. Dr. Desai trained in DR at Brigham and Women's before going on to IR residency at University of Virginia. And then he came back to Brigham as actually the first IR fellow to do anesthesia and the surgical critical care fellowship, which is where he practices now. So he's going to be doing a talk to us today, so I will go ahead and hand it off to him now.
All right. Thank you very much, Sejal, and thanks to the WCVIS for giving me this chance to talk to you guys about something that's, I'm very passionate about, which is how do we go from proceduralists to true clinicians? And so part of that, or really half of that for me, is the ability to manage acutely sick patients. Whether that's peri-procedurally or even consult on these really sick patients who are in shock or respiratory failure or whatever. I think that that's the evolution of IR. And so given my background and my training, I'm really excited to be able to kind of share some of my knowledge that I've gained over the years with you guys. So today we're going to talk about obstructive shock. It's kind of a mystifying topic. And pulmonary embolism and how the two relate to each other. So a brief outline here. We're going to do a little review of shock. We're going to talk about distributive shock and what it is. And then we're going to talk about, sorry, not distributive shock. I meant obstructive shock. And then we're going to talk about obstructive shock due to massive pulmonary embolism and kind of the sequelae of that. So starting out with the case here. So we have a 55-year-old female. She's got some comorbidities, COPD, sleep apnea, hypertension, heart failure. And she developed severe right leg pain and swelling after a flight from London to Boston. So pretty long flight. So when she comes to the ED, this is what you see, right? An asymmetrically swollen and red right leg compared to the left. Of course, your first instinct is going to be to get a ultrasound, and that shows and kind of confirms your obvious suspicions of deep vein thrombosis in the right leg. So I'm not going to get into really the very, very early management because this is something that, everybody learns in med school. It's kind of a knee-jerk response. It's a step one question. So you see a DVT, you start heparin drip, unless, of course, they have some sort of contraindication to anticoagulation. But let's say in this case, you started a heparin drip, and the DVT was so extensive and the patient had such bad symptoms, and you happen to be working in a hospital where people really know about IR and what we can do. They go ahead and just consult you guys. They consult IR for consideration of some sort of treatment for DVT, right? However, when you get there, the patient says, "Hey, doc, I'm having some chest pain and some shortness of breath." And then when you're speaking to her, you glance up at the vital screen, and it shows her blood pressure is 88/61, and she's tachycardic, and maybe she's a little hypoxemic as well. So what do you do, right? Well, looking back at this stuff, you got to kind of put things into buckets. So this person has a DVT, you know that, but now you've noticed that she's developed chest pain, shortness of breath, but almost most concerningly here is that her blood pressure is dropping. Let's say this is not a normal blood pressure for her. So immediately when you notice some sort of acute change in blood pressure that's going down associated with tachycardia, you always have to kind of, in your mind, light bulbs have to go off for shock, right? So, this lecture is about shock, and namely obstructive shock. So let's talk about shock and what it is. You learn about it in med school, but really fundamentally what it is tissue hypoxia from inadequate oxygen delivery and or impaired tissue oxygen utilization. So there's a mismatch here basically between oxygen delivery and oxygen uptake. And in today's lecture, or whatever we're talking about today, really we're going to be talking about poor oxygen delivery. And in most cases of shock, that's really what you're looking at. So shock is one of those things, you kind of just know it when you see it, but there are certain ways to diagnose shock from an objective standpoint. So I kind of group them into two buckets. There's indicators of impending shock, things like low blood pressure, low cardiac output, or an index if you have an easy way of measuring that. And then generally a low or an abnormal central venous oxygen saturation. So like a VBG that you draw from a central line, for example. And then there's markers of actual ongoing end organ hypoperfusion, basically actual shock that's going on. So things like a low urine output or peripheral vasoconstriction and skin changes from that. Altered mental status, shock liver that you'll see on the labs, and most classically lactic acidosis, so an elevated lactate, and an arterial base deficit. So when you get an ABG, you also get an arterial base deficit, and if there is a base deficit, it tells you that there's just more acid in the blood, and most commonly in these patients, that acid is lactate. So essentially a base deficit, when you hear people talking about that, really what they're looking for is a surrogate marker of lactate buildup. This is the most, I dare say this is the most important slide in this lecture, because if you understand this slide, then you understand shock and why shock is happening. And if you understand why shock is happening, then it's almost like a algorithm where you can figure out how do I fix this patient's shock. So what is the pathophysiology of shock? In terms of cardiac output, right? So there's several important parameters that you're looking at. Number one is the RV. So within the RV, you're looking at RV filling, right? Because if you underfill the RV, you're not going to be able to pump as much out of the RV. And if you don't pump as much out, the LV is not going to get as much, and your cardiac output's going to drop. You're looking at RV afterload, namely the pulmonary circulation. And obviously, when we're talking about pulmonary embolism, that's a very, very key factor, because a big pulmonary embolism is going to really drive up that RV afterload. And then RV contractility, right? If your right heart is not pumping well, then of course you're not going to get good forward flow into the LV. Similarly with the LV, you're looking at all those measures, right? So LV filling or LV preload, LV afterload, and LV contractility. When people talk about classic cardiogenic shock, meaning poor forward flow out of the heart, really what they're talking about is LV contractility, right? HFrEF, which is heart failure with reduced ejection fraction. Then there's other parameters of hemodynamics, including the systemic vascular resistance. So that's kind of like your vascular tone. People in septic shock have vasodilation. People who get anesthesia get vasodilation. So if your SVR drops, what's the problem with that? Well, too much blood pools in your peripheral circulation, not enough of it returns back to your right side. And now again, you're in the cycle of poor RV preload, poor LV filling, and then poor LV output. And then your PVR, so your pulmonary vascular resistance, again, that's kind of almost the same thing as RV afterload, where if you have a high pulmonary vascular resistance, your right heart is going to have a hard time pumping out. All right, so let's get into this. This is kind of the classic table, what you learn in med school. What is the pathophysiology of the different types of shocks, right? So you have the classic categories are hypovolemic, distributive, cardiogenic, and obstructive. Hypovolemic shock, examples of that are things like hemorrhage or just being dry, basically intravascular fluid loss. And this is kind of my favorite column. I'm going to keep referring to this throughout this talk, you need to know your underlying pathophysiology in all of these categories, right? So in hypovolemic shock, you have poor RV filling, which leads to poor LV filling, which leads to low cardiac output, all right? Distributive shock, like I was talking about, is where your systemic vascular resistance drops, okay? So that's in cases of sepsis, anaphylaxis, neurogenic shock, adrenal shock. Within distributive shock, people tend to compensate really well early on. And so you're going to get a low SVR, meaning you're going to get peripheral vasodilation, but your cardiac output's going to be preserved in early distributive shock. But what happens is eventually you're not able to keep up with that. And you eventually, like I was talking about, get your blood pooling in the periphery, which leads to poor RV return and poor RV filling, which leads to poor LV filling, which leads to low cardiac output. Cardiogenic shock is very simple in some ways. It's inherently impaired cardiac output, either from arrhythmia, an acute MI, some sort of cardiomyopathy, or acute valve failure. Essentially, you are just not having any forward flow out of that left ventricle. And then, what we're talking about today, right? Obstructive shock. It's kind of like a very mystifying category because people don't understand, what is obstructive shock? You kind of hear colloquially, okay, it's poor filling or constriction of the heart. But let me dig into this a little bit, okay? So I break obstructive shock into two categories. You have your pulmonary category and your tamponade category, okay? With your pulmonary category, you have things like massive pulmonary embolism or pulmonary hypertension. What those things can do is essentially cause a high RV afterload. If you go back to this picture, a big pulmonary embolism is going to block all the circulation, which causes high RV afterload. The RV has to pump against a lot of pressure. What that ends up doing is causing poor RV output and high RV distension. All right. So your RV is going to get blown up because it just can't it can't generate the pressure that it needs to overcome this obstruction. And so it blows up, it dilates. That dilation in turn leads to impairment of filling of the LV because that interventricular septum is going to bow into the LV, and the LV just is going to be constricted by the RV and is not going to be able to fill adequately. Well, what happens when the LV doesn't fill is you get poor preload and you get poor output as a result of that. So the Frank-Starling law is what you get in is what you put out, basically. So if you have low preload in the LV, you're going to have low cardiac output out of the LV. And that is the underlying kind of pathophysiology of shock in obstructive pathophysiologies. When we talk about tamponade, it's slightly different, right? Because in cases of like tension pneumothorax, compartment syndrome, pericardial tamponade, what's happening is that the entire heart can't fill because there's too much afterload. When there's too much afterload, both the RV and the LV can't fill, and you get low cardiac output. So overall, the general common pathway for obstructive shock is still poor RV filling or poor LV filling, leading to low cardiac output. But the things that generate that poor LV filling are different when you look at pulmonary and tamponade etiologies of obstructive shock. All right, so generally when we have a patient who's in shock, it can be very overwhelming. What do you do, right? Because there's so many different things going on at once. I kind of simplified it here into three big tenets. And this is not like a do one after the other kind of thing. It's not a 1, 2, 3 or ABC. This is, you're doing these three things kind of all at once and together and concurrently. But the big things are supporting your cardiac output, identifying hemodynamic derangements, so the underlying hemodynamic derangements in that particular patient. And then you're going to diagnose and fix the underlying etiology. All right, so now we get to this thing that you learn in med school where, people talk about the up and down arrows, what's high, what's low based on the PA catheter. Hopefully when I've gone through now this underlying pathophysiology in each type of shock, you'll be able to a little bit better understand what are the true hemodynamic derangements that happen in shock, right? So, I'll kind of brush over these three categories, but the main thing in hypovolemic shock is your CVP, which is a measure of your preload, essentially. It's an indirect measure of your preload, which I'll get into, but it is nonetheless a measure. That's going to be low because your preload's low. And as a result of that, your left heart filling, of which the wedge pressure is kind of the indirect measure of your left heart filling, will also be low. All right. In distributive shock, your SVR is down. We talked about that already. And in cardiogenic shock, your cardiac index is down. We talked about that already. So in obstructive shock, right, in the pulmonary category of obstructive shock, your cardiac index is down. That's the main derangement. And why does the cardiac index go down? Well, it's because you have poor RV filling. So now here's the question, right, is if you have poor RV filling, why is your CVP elevated? The reason for that is that CVP is a measure of pressure, but really what we care about is RV volume or filling. And so this is where you get kind of discordance, right? Because in reality, what's happening is that you're getting high pressures in that RV because there's an afterload that's happening, but you're also getting very high pressures and filling of that RV or dilation of that RV at the same time. All right, so the CVP will actually go up as a result of that, even though your RV filling in the end is actually kind of poor. And because the RV filling is kind of poor, the LV filling will be poor as well. So your wedge pressure will go down. Now, I want you to differentiate this because this is how you tell the difference between a pulmonary cause like massive PE versus a tamponade cause like cardiac tamponade of obstructive shock. This is the main difference, right? Is that your wedge pressure in cases of cardiac tamponade are going to be elevated because you have a constriction and you have poor, even though you have poor biventricular filling, you have elevated pressures in the LV in tamponade, whereas with massive PE, you have low pressures in the LV. So that's kind of the underlying difference here. In the end, just being able to differentiate, what's the underlying driver based on the PA catheter is going to be important for you guys. And then in addition to the PA catheter in modern times, everybody in reality is going to get an echo. So you guys should be familiar in general with what are the echo findings in these different categories of shock, right? So in hypovolemic shock, if you're dry, your RV is going to be collapsed. That kind of makes intuitive sense. And your IVC is going to be collapsed. That also makes intuitive sense. As a result of all that stuff, your LV is eventually going to be underfilled, right? So that makes sense. In distributive shock, like sepsis, a lot of times you're actually going to be hyperdynamic because your body is sending signals to the heart to become hyperdynamic, higher heart rate, kind of trying to tighten up the afterload, things like that. But in late distributive shock, it looks a lot like hypovolemic shock, right? So you're going to get a collapsing RV and an IVC and an underfilled left ventricle. In cardiogenic shock, you're going to have impaired ventricular contractility. I mean, that kind of makes intrinsic sense. Of course, you're going to probably see other findings, right? So if someone is having an arrhythmia, you're going to see the ventricle beating irregularly. If someone has an acute valvular pathology, if you're skilled enough with the echo, you can see things like regurgitation or stenosis. And then when you get to obstructive shock, I'm going to go a little bit more into detail here, but these are very, very key findings that truly, if you want to, be an expert in treating pulmonary embolism and, not only do these amazing kind of life-saving therapies that we can do, but truly be an expert in treating PE as a disease in and of itself, you really should be familiar with the findings in the heart and of hemodynamics of massive pulmonary embolism or right heart strain. So I'm going to hammer on this point. This is the first time I'm going to make this point, but I'm going to make it throughout the entire talk. Massive PE causes right ventricular failure. And that should make sense based on the pathophysiology of it. So if there's right ventricular failure and right ventricular overload or dilation, what should you see on echo? Well, you should see a dilated RV. That makes sense. You should also see decreased RV contractility. So something called the TAPSE, which is actually not that hard to measure. Basically, you're just measuring the movement of the tricuspid valve when you're looking at your echo. That's going to be depressed. You're also, in very bad cases of RV failure, you're going to have septal flattening and bowing going into the LV. Again, like I mentioned, that's the underlying pathology that's going to cause your LV to fail in causes of RV failure, right? Again, in RV failure, we're not necessarily worried about the RV itself failing, right? We're worried about the RV failing, causing dilation of the RV, causing thereafter LV failure. That's what we're really worried about. You're also going to have a plethoric or a dilated IVC. And then when you talk about tamponade, there's kind of certain classic signs of tamponade. Again, it's kind of nice to at least be familiar. You don't necessarily have to be an expert in doing an echo or diagnosing cardiac tamponade physiology, but just understanding what these terms mean, I think, is pretty important. And so seeing a pericardial effusion, seeing right atrial free wall collapse, RV diastolic collapse, and then normalization of all pressures across all chambers, those are classic for cardiac tamponade. And then we talk about the diagnostic tests, right? So these are kind of the things that they should be a knee-jerk reaction, right? So if I'm thinking someone's in hypovolemic shock, I'm going to take a look at their hemoglobin to see if they're bleeding. I'm going to take a look at their creatinine to see if their kidneys are working okay. Look at the lactate, look at their intravascular fluid status, which is something for another lecture, really. We should at some point talk about differentiating shock in general and how to diagnose shock in general. That's a different topic for a different day. For distributive shock, you're really thinking of sepsis. So these are all the sepsis labs that you should get, infection labs, and also things like cortisol, procalcitonin. And then in cardiogenic shock, you got to make sure the patient's not having an MI. So get an EKG, get a troponin, get a BNP to see if they're in heart failure, and then get an echo and really float a swan is what either you or the ICU team needs to do. When we're talking about obstructive shock, right? So if you think you have a PE, get a CTPE. That's pretty self-explanatory. If you think someone has tamponade, get a chest X-ray, get a chest CT, get an echo for sure in both of these causes. And then if you think they have abdominal compartment syndrome, you should get paralyzed bladder pressures to be accurate. All right, that's a lot of information, but we'll kind of work through it. So let's go back to our case, right? We get an EKG because we are concerned that this patient who had a DVT might now have a PE, right? Or maybe in some sort of a cardiogenic shock picture. So we get an EKG, and this honestly looks like a pretty normal EKG, right? Which in cases of pulmonary embolism, the most common EKG finding is a normal EKG. So you do get a troponin, and it's slightly elevated at 80, and then you get a BNP, and that's slightly elevated too. And so you've kind of at this point diagnosed this person probably has an NSTEMI. Now, is that intrinsic coronary disease causing the NSTEMI, or is that something else, right? Is that demand on the heart? And so at this point, you want to get an echo. And so you get the echo. Hopefully, guys, you can see the movement of this echo. It's a GIF, but really what I want to point out here, what we're seeing, is that there's no wall motion abnormality. So the LV is fine, telling you that there's not like a big myocardial infarction going on. But what you're seeing is called the D sign, which is the RV here looks like the letter D, and it really shouldn't, right? It should be smaller than the left ventricle, but here it's very dilated and it's pushing into the left ventricle. And so that tells you right here that this patient has right ventricular dilation and potentially right ventricular failure. So you would measure a TAPSE, meaning you would get pulse wave Doppler on this location right here. Sorry, not pulse wave Doppler, you get M mode imaging. And then you would measure the peak to the trough to this location right here again. And that'll tell you, is the RV moving like it should? Basically, that's all it's telling you. And if it's not, then you're really, really highly suspicious of this etiology, right? So you get a CTPE, and this patient has what we call a saddle pulmonary embolus. All right. So let's talk about obstructive shock a little bit more. So there's three big etiologies. And again, there's two big buckets, right? There's the pulmonary kind of pathophysiology, and then there's the tamponade physiology, which I kind of lump cardiac tamponade and tension pneumothorax into the same kind of categories. So again, the pathophysiology with massive PEs, you get high RV afterload that causes poor RV output and high RV distension, which leads to poor left ventricular filling and a low cardiac output. Whereas in these two causes, again, you're getting constriction of that heart. And because you're getting constriction of the heart, both ventricles can't fill, and you're getting a low cardiac output as a result of that. So this person has a pulmonary embolism. Let's get into the meat of the talk today. How do you manage pulmonary embolism as a whole, right? Including someone who's hemodynamically unstable. So your first differentiation is going to be, does my patient with PE, are they hemodynamically stable or are they unstable, right? And that'll tell you exactly what to do in an algorithmic fashion once you've determined that. So let's start out with this category, the hemodynamically unstable patient with pulmonary embolism. You're going to anticoagulate. That's like almost a knee-jerk reaction unless they have some sort of contraindication to anticoagulation. At that point, you can have a discussion with your procedural specialties, which is yourself, as to, should I get an IVC filter? Should I talk about more aggressive catheter-directed treatment? We'll get into all that later, but you anticoagulate if you can. And then step two is you need to treat RV failure and the shock, right? That should be your first step, is to stabilize the patient. And then you can think about, doing all your fun stuff, your thrombolysis, your thrombectomy. But the first thing you need to do is to treat the RV failure and the shock. And this is the most important point, probably from today's talk, is that as interventional radiologists who treat massive PE, because we come in this step normally, but you really should know, if not be comfortable with treating RV failure and shock. All right, so let's talk about that a little bit. This is the classic death spiral, quote unquote. That's a very ominous term, but it's a catchy term too. This is what happens when your right ventricle fails as a result of having a huge pulmonary embolism. All right. You get RV dilation, which leads to increased RV wall tension, which leads to increased RV oxygen demand. Then you start getting RV ischemia, which leads to poor contractility of the RV, which leads to poor RV output, which then leads to poor LV preload, which then drops your cardiac output. And you just start circling the drain, right? Because if you get poor LV output, then you get obstructive shock, you get poor perfusion, your heart works even less, and then you enter this death spiral, as they call it. So how do you escape? How do you abort this death spiral? That's what we're going to talk about. The first step of that is to look at the echo, right? You want to know how bad is this RV failure? How bad is the RV dilation? So I already talked about this a little bit, but this is what TAPSE is, right? So you want to see what degree of RV failure do I have actually? And you're taking this M mode on the apical four-chamber view of your echocardiogram, and you're measuring the movement of this tricuspid valve right there. And if it's less than 17, this is actually an error right here, that should be less than 17, then your RV contractility is decreased and you have RV failure. There's a similar measurement called the S prime velocity. You know, it's a similar concept to the TAPSE. You can learn it if you want to, but the easier thing to do is to just do a TAPSE. And then this is the quote unquote D sign, which we saw in that in the echo that I showed you just a little bit ago. This is the RV bowing into the LV, compressing it and preventing it from filling adequately. So how do I manage RV failure? Let's say, you know, I've confirmed on my echo that my patient has RV failure as a result of PE. These are the central tenets, right? So number one, reduce your RV afterload. Number two, optimize your RV preload. And number three, support or maintain your blood pressure and your cardiac output. You know, it's three simple tenets and they may sound simple, but this is the core of what separates you from being able to save a patient's life from not. So how do I reduce the RV afterload? And you got to go all the way back to think about your pathophysiology, right? RV afterload, for all intents and purposes, equals pulmonary resistance. You can think about it that way. So how do I drop my pulmonary resistance? Well, one of the best things to do is to give the patient good oxygen, right? And so if you put someone on 100% oxygen with a high flow nasal cannula or a BiPAP if they need it, then what you're doing is you're vasodilating those pulmonary arteries and vessels. And as a result, you're lowering your pulmonary vascular resistance. Avoid intubation. This is a very important point here, right? Because your knee-jerk reaction may be, especially in these patients who have hypoxemia from their pulmonary embolism, all right, I got to immediately intubate this patient. But the problem with that is that the process of intubation inherently involves hypoxemia because they go for a period when they don't get oxygen. They get hypercapnic as a result of that. They get positive intrathoracic pressure and they get sedation. All of that decreases your RV preload, right? And if you decrease your RV preload in someone who already has RV failure, you're very quickly going to precipitate a cycle that puts them into cardiac arrest. And this doesn't happen infrequently where you induce someone for intubation in someone who has a massive PE and they code. That's like a very common story. And everybody's afraid of that happening, right? So you want to avoid intubation at all costs. If they're already intubated, then you want to avoid positive pressure as much as you can. So that means minimizing your PEEP. And here's my favorite, little trick here is inhaled pulmonary vasodilators. There's not a whole lot of high-level research on this, but the great thing about these things is that they're low risk and they really do work on an anecdotal basis to lower that pulmonary vascular resistance, right? Their mechanisms are simple. Really they're mechanisms of things like nitroglycerin or milrinone, nitric oxide. My favorite is Volitri, which is epoprostenol. You put it nebulized through either the endotracheal tube, or sometimes even people can do it through high flow. And these agents get into the lungs and they dilate the pulmonary capillaries. That's all they do. But by doing that, you're dropping your pulmonary vascular resistance, you're dropping your RV afterload, and you're helping your RV work just that much better. So think about using these agents if you can. Make the recommendation, to use these things in these patients who are unstable from their PE. Second step, or second tenet, is optimizing RV preload. You've heard a lot of things about probably in med school about how the Swan-Ganz catheter is going out of favor, about how it's not associated with increased or better mortality in the ICU. That might be true, but in reality, the Swan or the PA catheter is actually like a wonderful tool to use. It's a wonderful diagnostic tool. It gets a bad rep because, things like when you're measuring central venous pressure, right? And central venous pressure is something that's gotten a really bad rep. You might have heard in the ICU, oh, don't listen to the CVP. It doesn't really mean anything. That's true when you're using the CVP as an indicator of LV filling, because the RV or the right atrium doesn't really see exactly what pressures the LV is seeing. But if you're talking about, and if you're interested in RV preload, measuring CVP is actually your ideal value to measure, right? So get a central line in these people or get a PA catheter in these people and measure the CVP. And you're going to target a CVP of 8 to 12 millimeters. And the reason for targeting that is because the RV itself is very sensitive to falling off the Starling curve. What that means is if someone is dry, if they're underfilled, it's going to hurt your cardiac output. And because it's going to hurt your RV filling and RV output. By the same way, in the same token, if the RV is overfilled, it's not going to be able to pump out either. And so if the RV is overfilled, then you're going to drop your cardiac output as a result of that as well. And so you really want to optimize these people on the Frank-Starling curve. And you do that by diuresis, right? So you use an IV loop diuretic like Lasix or Bumex. And then you can even add a thiazide, right? So you can use metolazone or you can use diaryl chlorothiazide to augment that diuresis. So be very cognizant of what these patients' CVP is and adjust accordingly. All right, and then tenet number 3 is supporting the MAP, supporting the cardiac output. This is the fun, the fun in managing these patients is using pressors and using mechanical circulatory support. All right. So pressors, which pressors do I use? You might have heard like Levophed or norepinephrine is kind of the general pressor of choice to start the undifferentiated patient out with. And that might be right. That's not a bad choice. But in cases of RV failure and pulmonary embolism, really your goal is to drop this number, like I talked about, to drop your systemic vascular resistance while still increasing your cardiac output. The problem with most pressors is that they increase your cardiac output by increasing both your systemic vascular resistance and your pulmonary vascular resistance. What you really want to do, the ideal pressor in cases of RV failure is one that decreases your pulmonary vascular resistance, but increases your SVO. And by doing that, basically it'll allow the RV to flow forward, but it'll still maintain that peripheral pressure to maintain your MAP and perfuse your organs. So when we think about that in mind, right, really what we're talking about is a high PVR, a low PVR to SVR ratio. So which pressors do that the best? Turns out that there's 2, right? There's vasopressin, which is does its job by increasing the SVR more than it decreases the PVR, right? So in the end, vaso is a very good choice, and then epinephrine, which has both alpha and beta activity, will also actually decrease your pulmonary vascular resistance, all while increasing your systemic vascular resistance, right? So vasopressin typically at 0.04 units per minute, and epinephrine anywhere from 0 to 10, really. You can go up to 20, but 0 to 10 mics per minute is a good choice. So those are vasopressors, and then inotropes are their own category, right? So when we're talking about dobutamine or milrinone, the problem with these things is that they help your heart beat by their beta activity, right? So they help your RV and your LV squeeze. So that's good. That's what we want. But they also have this bad effect of dropping your peripheral vascular resistance. The nice thing is that they also drop your pulmonary vascular resistance, but these patients, if you give them just dobutamine, they might actually become hypotensive, even worse hypotensive, because you're dropping your systemic vascular resistance. So sometimes what people do is they do dobutamine and then they add vaso on top of that, right? So you're counteracting that systemic vasodilation with the vasopressin or the epinephrine or the levo, while still getting the inotrope effect of the dobutamine. So think about all these agents when you're thinking about RV dysfunction. All right, and then we're going to talk about devices a little bit because this is a very complex topic and it deserves its own lecture, but I'll do kind of a surface level thing of this. So what devices are you going to be thinking about in someone who has RV failure? Well, very fundamentally, you want to bypass the RV with devices. So you're looking for a device that takes blood out of the either the IVC, SVC, or right atrium, and with its own pump, pumps that blood up into the PA or into the systemic circulation, basically. And so there's 3 devices that are direct RV bypasses. You have your Impella RP, you have your kind of classic RVAD. Tandem is kind of just the trade name for it. And then you have your Protect Duo, which is a percutaneous RVAD, which is again another trade name. And then you have your indirect RV bypass, which is VA ECMO. And I'll go into VA ECMO a little bit in detail. All right, so these are just illustrations of what these devices are to give you an idea. So this is the Impella RP. It's really just a single catheter with two holes in it. One is an outflow and one is an inflow. The proximal outflow takes blood out, typically from the IVC or the SVC, and then it takes it out to a pump, and then the pump pumps it back out through these holes right here, and that hole is in the pulmonary artery. So you're bypassing the RV with the Impella. This is the Protect Duo. This is a really exciting device, honestly, because I think in my ideal world, I think every interventional radiologist who does PE treatment should be able to use and put in a Protect Duo, because this is a percutaneous RVAD. It's a single catheter. All you have to do is put it in through the IJ and snake it into the PA, right? So it's essentially the same thing as Impella, but even simpler. And so it's the same concept where it takes blood out of the right atrium, takes it out, puts it back into this pump. The pump accelerates it and puts it back through the inflow line, which then jets the blood out through the inflow holes into the pulmonary artery, right? Relatively simple pump. This is a classic RVAD, right? This is a central cannulation, so cardiac surgery has to do this cannulation, but same kind of thing, right? It takes blood out of the RA, puts it through the pump, and then puts it back into the PA. And then this is VA ECMO. Again, kind of the same, similar concept where you have a venous cannula, and so that venous cannula takes blood out of the vein, puts it through this pump, which also has an oxygenator in it. The oxygenator oxygenates the blood and puts that oxygenated blood through a second arterial cannula that you have in the femoral artery that goes all the way up to the aortic arch. And so you're bypassing both the heart and the lungs with this machine, right? That's crucial to know, because you're both pumping the blood, and so you're bypassing the heart, but you're also oxygenating the blood, so you're bypassing the lungs. So VA ECMO is what you need to use for RV failure. This is a little bit more detail about what these devices do. So like we talked about, the Impella inflow is from the right atrium, outflow is into the PA. Same thing with the classic RVAD, and same thing with the percutaneous RVAD, which is the Protect Duo. In the inflow from the RA, outflow into the PA. And you see both of these things have a flow range of 2 to 4 liters per minute, right? That's a typical cardiac output in an adult is close to 4 liters per minute, right? 4 to 5 liters per minute. So these things do very good jobs of being a surrogate for the heart pump. Really the difference between VA ECMO, of course, other than the oxygenator, is that with VA ECMO, you're also offloading the left ventricle. And I put this table in here because you also have to be cognizant that if the patient not only has RV failure, but concomitant LV failure, you really want to watch out for putting in these isolated RV devices, because what they'll do is they'll bypass the RV, but they'll also jack up the pressure in the LV because you're shoving all that blood down back into the LV. But if their LV is failing, they need something that supports both the RV and the LV, right? So you need to know which chamber and which side of the heart is in failure. And so if you have biventricular failure, really what you want to use is VA ECMO, because these other two things will overload the left side of the heart and cause pulmonary edema. All right. So this is the algorithm. This is actually a great paper. I actually highly recommend you guys check this out. It's in circulation and it talks about what circulatory devices to use in RV failure. But essentially, what it tells you to do is if someone has a PE, right, you really need to think, especially if they have hypoxemia from that PE, you really should think about VA ECMO. But, if they're holding their own from a respiratory standpoint, then you can start thinking about things like a tandem RVAD or a Protect Duo. But before you do all that stuff, you really want to make sure that they're also not an LV failure at the same time. And you do that by getting an echo, by looking at the PA catheter, by looking at the hemodynamic parameters themselves. So that being said, everybody kind of hates these numbers, right? Because it's very hard to memorize them, but it will, I promise you, make you a better vascular interventional radiologist, right? If you know the hemodynamics of the cardiovascular system, then you can make so much more intelligent decisions on medical management of these patients that you're going to be treating. So out of these values, it's really good to know what is a normal CVP, which is 2 to 6. What is a normal pulmonary artery pressure? So you're talking about a mean PA pressure of around 15. What is a normal wedge pressure, which again is a surrogate for your left heart filling? What's a normal cardiac output? What's a normal cardiac index? And then I didn't talk about this, but it's a very good, advanced hemodynamics measure to know, which is your PAPI or your pulmonary artery pulsatility index. If this index is reduced, then that's also another good sign of RV dysfunction. So in addition to the echo and the other values on this table, if you know what your PAPI is, that'll be another piece of data to tell you whether your patient's in RV failure or not. All right. So, we've determined that the patient is hemodynamically unstable, and we've brought them to not only a good amount of cardiac support, to support their RV failure. But from that standpoint, then the next thing to do is what we do, right? So, really this is where the typical IR comes in, is you've gotten them stable and now we're doing the procedure and we're not thinking about everything that I just talked about for the last 40 minutes. But you can see how it's so important to know all of the stuff that I just talked about to make you a better clinician and in the end, make you a better interventionalist, right? So let's say now we've gotten to the point where, this patient is actually hemodynamically stable, right? That's the other half of that algorithm. What do you do in a stable patient? Well, really you break it down into two things, right? Your job is to recommend one of these things by integrating all of this data. And so you want to recommend either anticoagulation alone or an IVC filter if that's more appropriate, versus systemic thrombolysis, versus catheter-directed thrombolysis or thrombectomy, versus surgical embolectomy. So how do you make that recommendation? You need to integrate all of this data. So the data that you need to integrate is whether there's evidence of right heart strain on the EKG by looking at things like, looking at your QT, elevation or depression. Those are kind of the most important factors, but looking at your R waves, looking at old Q waves, things like that. Looking at your troponin value. So if someone has a troponin leak, then that's actually the best indicator that someone has right heart strain. Get an echo. Again, I'm hammering that point, but getting an echo will tell you so much about whether the right ventricle is being strained or not. Look at clot burden, right? So what I haven't talked about is the classic, misconception people have is people think of clot burden and they think, okay, well, that's going to drive how I treat my pulmonary embolism. So if someone has a saddle pulmonary embolus, then that automatically means that they have massive pulmonary embolism and I need to do something active. When in reality, what drives it is the hemodynamics, which we just talked about. It's not the clot burden. However, clot burden is important because in someone who's hemodynamically stable, but they have a huge clot like our patient did, that might drive you a little bit more into the being aggressive with catheter-directed thrombolysis and thrombectomy or surgery, as opposed to just doing systemic thrombolysis or anticoagulation alone. If they have clot in transit, that's a very scary thing. It's like a snake-like clot that's sitting there in the RV, just waiting to go to the lungs. That's going to drive you more towards these kind of categories of intervention, right? Active categories of intervention. If they have hypoperfusion, even though, even some people can be hemodynamically stable, but they can still be hypoperfusing their organs. So if they have lactate, if they have a low mixed venous O2, if they have low urine output, that's going to drive you towards more aggressive intervention. And then this thing called the PESI score, right? So the PESI score integrates basically demographics, comorbidities, and general clinical findings, and you generate a score. And that score puts you in different classes, and the classes tell you what's your 30-day mortality. So if you look at these numbers here, particularly class 4 and 5, if you're in those categories, you're thinking more about being more aggressive with intervention. All right. So there's all these kind of algorithms and things like that, like I'm going to show you right here. And these algorithms can be kind of confusing, but in reality, there's no one true algorithm. Really, to put it simply, if you have a hemodynamically stable patient, you're trying to decide, am I going to be aggressive from an interventional standpoint, or am I going to be conservative from doing either systemic thrombolysis or just anticoagulation? And you make that differentiation by looking at things like the right indicators of right heart strain, or indicators of clot burden, or indicators of ongoing shock, right? You integrate all that stuff, and then that tells you how aggressive am I going to be. All right, well, a little word on thrombolysis, and I think I'm actually all done with this incredibly complex topic, so I have some time for questions. But if you've decided to go on the route of systemic thrombolysis, right, you want to be careful with the TPA. You really need to know, is there a contraindication to TPA or not? And that really is there some sort of head lesion? Has there been recent cranial surgery, spinal surgery? And are they really at a high risk of bleeding? So do they have concurrent bleeding going on elsewhere? If the answer to any of those things is yes, then you're in a very difficult situation with giving TPA. You can still give TPA at these kind of lower infusion rates or lower doses. There's really no set or gold standard dose of TPA that you're going to give. And so that's another way where we can kind of come in as IR clinicians and say, hey, look, I know, this patient from a PESI score standpoint or a RV strain standpoint might not necessarily be overall high risk, or you guys are leaning more towards just doing IV thrombolysis. However, this patient has a thrombolysis contraindication, and what I can do as an IR is offer IR thrombectomy. So thrombectomy involves no TPA, and it's incredibly effective. Again, that's an IR lecture to give, which I can certainly give, but that's a whole other lecture. But people, and particularly these companies like Inari and Penumbra, over the last 2-3 years have come out with really amazing data showing that pure thrombectomy without TPA in cases of massive pulmonary embolism can reduce mortality rates, sudden death rates, up to 90%. I mean, that's like a miraculous treatment, right? So if you know, where you are in this treatment algorithm, you can really go to the clinician yourself and say, listen, I can tell this person isn't really a candidate for IV thrombolysis, or, you guys are, I know, on the borderline for whether or not to do thrombolysis or not. Let me tip you one way or the other by saying I can offer you thrombectomy without thrombolysis and really have an amazing effect on this patient's life by doing that. But you're not going to be able to do that unless you know these algorithms, right? You're not going to be able to do that unless you know what RV failure and RV strain means. So hopefully by doing all that, I kind of gave you guys a broad overview of the hemodynamics of obstructive shock and of RV failure and of pulmonary embolism. I could go on and on about this topic, but I won't. I'll stop right there. please feel free to reach out to me. I'm happy to talk about all this stuff. I love doing these kind of acute care seminar series. If you find it helpful, let me know as well. And don't forget the SWAN. Don't forget the PA catheter. Learn about it, know the values, internalize it, memorize it, because it'll make you an amazing clinician. So that's all I got. Happy to take any questions.
Thank you so much, Dr. Desai. So yeah, like you said, at this time, we'll go ahead and open up the floor for questions. If anybody has any questions, you can go ahead and unmute yourself, or you can type it in the chat, and I'm happy to read it. It looks like we have a previous question from Dr. Vatican Cherry. Thoughts on inhaled nitric oxide or Flolan?
Yeah, I think the recommendation, honestly, with these inhaled pulmonary vasodilators is use what's available to you and use what's easiest to use in your unit. So I think it would be awesome if IR nurses, who at most places have to be ICU trained already and typically already have experience with using these inhaled pulmonary vasodilators, if we can get them trained, and if one agent is readily available and one is not, just go with the one that's available, right? So nitric oxide is fantastic. It doesn't really have a ton of side effects, other than the one to really watch out for is if someone is already in severe LV failure. What you can do with these things is you can drop their LV preload and therefore really crash their LV output. So you don't want to do that. But outside of that scenario, any of these agents are safe. So go ahead and use that inhaled nitric oxide, or like in our case at our institution, everyone uses Velitri, which is epoprostenol. And if you can get that nebulized really easily, go ahead and use it. I've also heard of people using just plain old milrinone and just nebulizing that themselves. If you want to do that, go ahead and do it, right? It's whatever's most easily available to you and your unit, and what you feel most comfortable with.
What rotations do you think they should get as MS4s ICU-wise?
Yeah, well, this talk is almost exclusively the cardiac ICU and the cardiac surgery ICU. So that's not something that's been traditionally in the wheelhouse of IR trainees. Most IR trainees end up in the surgical ICU. I know at my institution, that's where they end up. Sometimes you end up in a medical ICU, but we treat so much vascular disease that I think it's actually a disservice not to spend time in a cardiac ICU. It doesn't matter whether it's cardiac surgery or the coronary ICU, but if you have a cardiac ICU, spend time there, because that is where you're going to learn mechanical circulatory support. That's where you're going to learn cardiogenic and obstructive shock. That's where you're going to learn how to use your pressors and which pressures to use. And things like, RV failure, pulmonary vasodilators, all that kind of stuff. Those are the most high yield units, in my opinion.
It looks like we have another question. What are some scenarios where you think a patient with PE should get a Swan-Ganz catheter?
Great question. So to know that, you really need to know, what am I looking for with the Swan-Ganz, right? So in someone who is hemodynamically unstable with the PE, you want to know two things. Number one, you want to know, are they in RV failure acutely? And you want to know, number two, are they in LV failure acutely? All right. And number three, which is potentially actually the most important thing, is that going to change my management? So if they're hemodynamically unstable and you know that they need some sort of intervention, I wouldn't necessarily delay care by putting in a PA catheter. The scenarios where they're most useful really is in that hemodynamically stable but peri-unstable situation, or hemodynamically stable but concern for RV strain type of scenario. So in those scenarios, a PA catheter will tell you, it'll tell you your CVP, right? So it'll tell you your diuresis goals, which is great. It'll also tell you, do I need to start thinking about more aggressive intervention, right? Even though they're stable, do I need to get this RV clot out because they're starting to go into LV failure? And those are where I find that it gives you the most kind of bang for your buck in terms of pushing you in one way or the other. IV thrombolysis versus catheter directed versus surgery, knowing, what those values are. I will say there is a caveat, right? If they're teetering and you're not good, if you don't feel comfortable about your skills of putting in a PA catheter, you can do a lot of damage. And you can even do a little bit of damage, which is putting that Swan-Ganz catheter through the tricuspid valve incorrectly and opening up that tricuspid valve and causing tricuspid insufficiency. Because doing that itself may actually drop your RV preload and worsen RV failure on its own. So make sure you kind of either you yourself know how to float a swan or find someone who feels comfortable doing it. Those are kind of the only real caveats doing it. But if you can do it to help guide your therapy in cases where you're uncertain about what to do, I say 100% go ahead and do it.
I had a question myself. Are you routinely drawing a BMP or a troponin on any of your PE patients?
Let me actually go back to this algorithm right here. So a BNP is a great question, right? So what does a BNP tell us? A BNP essentially just tells us, is there dilation of the chambers of the heart, namely the right atrium, right? So it's helpful if the patient is very stable and you want to find out, okay, is there some sort of RV strain going on? But in reality, you're already going to get an echo because echoes are either easy for you to do yourself or easy to get at your institution. So in the end, the echo is going to tell you a whole lot more than a BNP is going to give you. So I actually don't necessarily like that test as much. If you look at this algorithm, which is from the European Society for Cardiology, the troponin is actually the deal breaker in terms of, is the PE intermediate high risk or is it intermediate low risk? And what that means is that intermediate high risk patients are more likely to get intervention. The intermediate low risk patients are less likely to get intervention and more kind of conservative management. So the troponin, I think, is a very kind of essential test to get. Obviously, if you get a troponin, you have to know all of the caveats of the troponin, right? So you have to know, do they have concurrent ongoing coronary disease going on? Do they have renal failure that's going to throw off your troponin values? Do they have a baseline elevated troponin, right? You need to know all that kind of stuff. But in the end, that is a very important test to get. Yeah.
Other questions we have in the chat are, what are your thoughts on high sensitivity troponins?
I do like them in this scenario because with PE, right, not only are you getting a lot of tests to corroborate your other tests, but you'd rather be more sensitive than specific, in my opinion, with these tests, because the fact that you're getting many tests outweigh or kind of cancels out any sort of low specificity tests that you're getting. So a high sensitivity troponin, we almost use that exclusively at our institution. And so, that's just kind of place to place will be different. But if you have it, I would say go for it, because even if you're being overly sensitive, your other tests will tell you if you're being overly sensitive and giving yourself a false positive or not, if that makes sense.
What do you recommend for the VIR who might feel apprehensive about diuresing patients to keep the CVP in goal range, given the classic thought of shock leads to more fluid?
Yeah. The short answer is trust yourself, right? So if you have a central line or a PA catheter and your waveform looks good, right? So that entails you having to know what a good central venous waveform looks like. But if the waveform looks good and the patient, for example, is not thrashing about, right? So everything is kind of stable and you feel comfortable about that CVP, and that CVP is still telling you, 14, 15, 16. You're not necessarily going to kill someone by diuresing them, right? So if you feel a little bit apprehensive about it, but all of your indicators are telling you, hey, my RV is dilated, you can give a little bit of diuresis, and you can always counteract diuresis by giving fluid. So don't feel apprehensive about it. In fact, think about, am I, harming this patient by not being aggressive with the diuresis? And number two, learn echo. And by learning echo, I don't mean, learn like how to do a full echo. All I mean is learn the 4 basic views: peristernal long axis, peristernal short axis, subcostal, and apical four-chamber. And for a radiologist, in the end, all interventional radiologists are radiologists, right? So that is not hard for anyone to be able to pick up. It's really not. And if you can get an apical four-chamber view and you can see that the RV is dilated and your CVP is elevated, that's all the information you need. There's no need to be apprehensive at that point. Just go ahead and do the diuresis.
All right. Well, if there are no more questions, we'll go ahead and wrap things up here. Again, thank you so much, Dr. Desai, for giving this presentation, and thank you everybody for attending and giving your time over here today. Is there any last minute things you want to go ahead and say, Dr. Desai?
No, I think that's it. I'm really excited that you guys are excited about this, and I hope more trainees kind of participate and get excited for acute patient care, because this is, in the end, it's a part of what we do. Surgeons do it, cardiologists do it. We should do it too. So thanks for participating, and thanks for everyone who watches this on YouTube. Please feel free to reach out to me, and thank you, WCVIS.